we say we didn't support it because we don't support the regulations. We think there are some concerns about the science, but we do support the techniques in principle because they'll provide hope for people with this disease. So it has to be, absolutely. And then you saw Bishop Carey come out in the House of Lords saying, I do support this again. So it really comes down to, I think, the ability to have that open debate and recognising that people are open to and will always have their different positions. It comes back down to the issue of patient choice.
I'd just like to echo that. I think to date, to my knowledge, although I think David might have a comment too, but we haven't had the public dialogue in Australia yet, so we cannot be absolutely certain what particular groups will say. We can perhaps sort of impute some previous debates from, say, IVF technology or the cloning debate into this area too, and we could predict what some responses might be. However, I think another comment to make is I'd be quite mindful of saying the Jewish response or the response from Islam in a completely different context. I once wrote an academic paper where I was seeking views from members of particular religious groups on a certain biomedical technology, and the message that I received very clearly was if I'm a rabbi in a synagogue, my role is to counsel, my role is not to tell what to do. And I think the same message came through from imams in Islam, is that we encourage people who follow our doctrine to choose their own path with our guidance, but we are not there to make decisions on the individual basis. So I think that would be very much the way that I would expect the debate to go in Australia too, that there will be arguments framed around lots of different contexts, and religion would be one component of that. And I think particularly given the sort of inherent ties, I guess, between the contested nature of an embryo and the religious doctrine that informs some of that.
We have another question here. Just to sit to that microphone.
You were doing very well before, but you seem to have lost the
No, I'm doing that on purpose.
Yeah. It's all about distance from the...
I'm scared of it. I thought it was remarkable, the cases where there was this really delayed onset of the mitochondrial diseases, and I'm interested in, I don't know, how does that happen in that the tissues are functioning perfectly normally and then all of a sudden they stop functioning? And in the case of like your family, is it known what the mutation is and how that affects mitochondrial replication?
Yeah, there's not one simple answer to that, but there's a number of things. I mean, like a lot of metabolic diseases, patients with mitochondrial disease can be functioning and they might have no reserve capacity for things. So we have a mouse model with mitochondrial heart disease, and its heart is going flat out the whole time. You try and stress a normal heart and it has a capacity to respond. These mice are just going flat out. They suddenly basically lose weight, go into cardiac failure, for no apparent reason that we can detect. But patients with metabolic diseases in general are often very susceptible to metabolic stresses, infections and so on of one sort or another. There's all sorts of reasons with mitochondrial DNA mutations. I mean, it could be that for some mutations the amount is actually increasing during lifespan in muscle or brain, but more likely it's just the demand for energy changes during life, changes in different circumstances, and there's a threshold that they can get by on, and something pushes them over the edge.
Well,
the cochlea are very sensitive on it, but again, it's certain mutations you see hearing loss, like the MELAS. It's very, very classic, that sort of deafness in the 30s and 40s and so on, and it's also often accompanied by diabetes, that mutation.
And with respect to that, the age effect, that's fairly dramatic. Is there any evidence? I think, Damien, you might have been talking a little bit about this in your talk, that with age that there's an increased selection of the abnormal mitochondrial DNA, or increased accumulation of abnormal mitochondria. Is there any evidence in the patient population for that or not?
I think, again, it's hard to be definitive about that because you don't really do serial muscle biopsies and so on patients, or serial brain biopsies. So you sort of have to look at population data, and so it's very hard to say yes or no. And the best data are probably for mitochondrial DNA deletions it's probably reasonable to think that the amount of the deleted molecule increases with time because it's smaller, and so long as the cells have enough energy, it replicates faster than a full-size genome. There are some data around the MELAS mutation, the common MELAS mutation, that maybe it increases, but yeah, it's really hard to give a definitive answer to that.
Okay. Any further?
We're talking a little about the carryover effect, and in relation to mitochondrial donation, the carryover of the DNA, and then how that might increase over time, or what issues that may cause. In terms of, is that an issue? Because ultimately, aren't we reducing? Isn't this technique reducing the amount of mutant carryover? So, if you've got, say, a woman who might have an embryo that's naturally conceived and one that's generated through mitochondrial donation, isn't the one with a lower mutant load better off anyway?
Yes, I agree with that, and Mary raised that point too. I mean, you're lowering the risk anyway. I guess it becomes an issue if the carried over mutated mtDNA consistently outcompetes the wild type donor mtDNA, given potential time and effort and costs involved, particularly the patient. They know that the disease is then likely to manifest down the track at some point, maybe not in the offspring's generation, but in the grand offspring. And I guess that becomes an issue, potentially not a safety issue per se.
Right. But is part of the argument in that situation that as a result of mitochondrial donation, the rate of preferential selection would be different, so it would amplify at a different rate of acceleration than a normal, naturally conceived embryo? Is there thinking of that there might be difference as a result of the intervention?
There's evidence, there'll be more evidence coming out this year that I'm aware of, that different mtDNA backgrounds of the types have different rates of drive, replicative drive. So it's possible that the mother's mutated mtDNA molecules, if they're in heteroplasmia with some putatively healthy mtDNA molecules that she has, the ratio of the speed of drive might be slower in the donors that when that mutated mtDNA is transferred over to the donors that are trying to have a type matching to fix that problem. But that is quite speculative. But
I mean, I can talk quite loudly. David, you've talked a lot about grandchildren in the sense of like this, in the sense of mitochondrial donation and mitochondrial DNA. How relevant is that when you're looking at the fact that this technology is going into use now, children are being born like over the next kind of 10 or 20 years, and their grandchildren are maybe 50, like their offspring are maybe 50 years down the track? Like, is it particularly relevant to say like that this disease may manifest in someone's like grand offspring when like science probably progressed a really long way again by then, so we may be getting consistently 0% cancer?
I think it's relevant that patients that will opt to either have or not have this technique have that information at hand when they make a decision. So I think therefore it's our obligation as scientists to put it on the table. That's what we've done with the HTA consultation. I'm really hoping that those issues don't manifest in the technique works out, which is great. So I think the more information the patient groups have when they make those decisions, that's the decision.
Another question for you. Like you mentioned that it is very important that mitochondrial gene and the nuclear gene, they maintain a proper allelic combination, and that is important for survival, zygote. The X chromosome and the mitochondrial gene allelic combination is important. That's what I understood. If I'm wrong,
Yes, so
so in conclusion to that, I was just thinking, if there is a female, and definitely the female is having one X chromosome from the mother, and another is coming from father. So if X chromosomal gene and mitochondrial gene allelic combination is so very important, then at a time, maybe in one egg, the maternal X chromosome is combining with the mitochondrial gene, and the very next time, the father's X chromosome may combine with the same mitochondrial gene and elements. So how, and you said that this particular X chromosome allele combination is important, and it may affect the survivability and compatibility among these two. So if naturally it is possible, definitely it is possible, because it is not every time the same X chromosome is going to combine with the same mitochondrial gene copy. So how it is not possible that mitochondrial donation is actually not going to help? I don't know. That's my question.
So what you described as simple laws, segregation, mendelian segregation, and then selection can act on the combinations that might not inherit key mitonuclear allele combinations. And that selection might happen during follicular atresia, right? So by the time the eggs that are presented to the male gametes will, if there was a vital mitonuclear allelic pairing that was essential for life itself, no oocytes would ever get through to the mature stage unless they had that pairing. And the number of oocytes that don't make it would massively outweigh the number that will make it in a lifetime, of course. So selection can act there, it can act after conception, it can act after fertilization, it can act after birth. But the whole reason why sex has evolved is not every living organism has sex, only eukaryotes, is because it creates this genetic variation and recombinants upon which natural selection can then work. Right? What is it about eukaryotes? They all have mitochondria and they all have sex. They're the two defining things about the eukaryotes. So I think that those two things are highly related. And so the natural selection is the job of optimizing the mitochondrial
I'm just interested to know your opinion about perfectly healthy people having a debate on, treatments that can be beneficial for people with mitochondrial diseases that are terrible diseases. So me particularly, as a healthy person, I don't feel like I have the same, a technique that's potentially beneficial. It's beneficial for people with mitochondrial diseases. So why should we be debating something that's good for people with mitochondrial diseases?
It's a really good question, and it comes down to a lot of things. How can a majority decide a decision that would benefit a minority? Look, I don't get involved in the politics of this debate, and I'm pro mitochondrial donation in the sense that I want to see this work for donations. But I feel an obligation as a scientist that I contribute areas from my research when consultation before the evidence from these consultation bodies that present that evidence, and then the authorities.
I'll just add to that. I think your question is a really important one. I think one thing to be absolutely clear about, and Nancy can attest to this more, is that the UK developments have happened very much in partnership with patients, and the AMDF here in Australia has a strong connection with patients, very strong advocacy for on behalf of patients. However, if we're running sort of a procedural society that takes sort of deliberative democracy seriously, really important decisions like this need to be made by more than one set of stakeholders. So this is a partnership decision that's going to involve lots of people like us and patients too. So I think it's not a decision or something that can be done alone by a particular group. It's going to have to be something that brings lots of different stakeholders to the table to have the kinds of discussions involving the elements that we talked about here.
Just to reiterate that, and at the end of the day, as David says, I think what is important is that you provide those who will be choosing this and weighing up the benefits and pros and cons, that they have as much information that is available to them to be able to make this decision, because it's a life-changing decision either way. And talking about reproductive technologies, and I'll hand over to Mary. ACSA as well, we hear from so many women that is it rational or not that they want to have children that are genetically related to them, but you need to set out the information at hand as to what the risks might and might not be.
I just wanted to say that in the UK there were scientists as well and flight engineers who were raising those same concerns related to the correlation of mitochondrial and nuclear genomes. And it was felt, okay, that's a theoretical risk based on laboratory trials and mice as well. But we've got the same mix of nuclear and mitochondrial alleles, being exchanged generation after generation after generation. And it's conceivable that things might become a bit fixed in that situation. But it was felt that on balance, the theoretical risk, that the benefits would outweigh this theoretical risk. I think it's important, we will hopefully be able to offer something to patients fully informed that, we can't say this is 100% safe until it happens. We can do in vitro studies to study the gene expression, to study anything else, predict it, go on. I can't say it's 100% safe until we do it, and research will be ongoing, I think, to test all about, and I think it's a myth to experimental systems to test them in predictions in there.
Can I just add briefly to that? Evidence is just coming out now about the safety of IVF procedures and possible health effects for children born from IVF procedures. So it takes a long time for evidence to come out, but generally the use is really good. There's a slightly greater incidence of certain sorts of diseases, but overall it's really good news. But when IVF procedures were developed, there were still some doubts about possible long-term impact, and it's going to be really important for this follow-up studies.
I have a question. Can I jump in relation to the reviews, etc., that were undertaken? So, Nancy, you talked about 3 scientific reviews in the UK. You talked about public consultations, the Nuffield Council on bioethics. So, to perhaps the legally informed people in the panel, all that's happened. Do we need to do that again in Australia? Can we just take that for given? What would be the approach here? And sorry if I threw you in the spot there, Zoe, but maybe if the NHMRC has a thought around that, surely we can leverage some of that, if not all of that, right?
Do you want Zoe to answer that?
I guess I can't really speak on behalf of government, and as you understand, the government's the one that would be driving any legislative change. I know that there is no current intention of reviewing the legislation. That said, there's also often context factors that they like to take into consideration in different jurisdictions. So, a lot of the times we will conduct our own evidence review even if there is international evidence reviews out there, because other context and policy factors that people like to consider might be able to be taken into that process. So I can't speak on what the government has planned in this space, and I guess we're in dialogue, I know, with the ministers, so I guess keep those avenues up and see how we go.
Can I say something quickly?
Yeah.
Okay, so I think 2 things. Although Australia was sort of initially, well, not initially, but Australia was colonised by the UK. Obviously, we had a very important first population, but our society makeup is not exactly the same as the UK. So I think there obviously needs to be consultation here. I think the other massive difference is that we're a federated nation, as Liz has explained, and our legal situation is very complex, and the sort of changes that are going to be required, because our current
Yeah, I just can I step in? Yeah, look, I think that's a really good point. The one about the fact that the UK are already there. That had 10 years virtually of informed debate about the whole issue. I mean, that gives Australia a great launching pad for this, absolutely. And you'd hope that it wouldn't take the same period of time. You'd hope you'd be able to make some progress much more quickly than that. Although it sounds like we're really going to get slowed up at the actual legislation time. But when you think about it, a mitochondrial disease patient in the UK is the same as one in the US, is the same as in Australia, and that's that's really the unified, the idealist ideal scenario, isn't it? And if we can we use that to try and move things along a bit, it might be helpful.
I was just going to comment that one of the differences, I think Australians have an idea that we're this very egalitarian society and the UK is a bit stuffy and so on, but it's incredible that this got through in the UK, and it's a testimony to the work of an individual centre which has, I don't know, 6 or 7 professors of mitochondrial medicine, and it's probably the only place in the world where there's such a concentration of people in all the relevant scientific fields, and that close interaction with policy advice foundation, and that's what made it happen, and there's actually reviewed it and so on. And in Australia, we have one of the most conservative governments we've had in a very long time, maybe less conservative than 10 days ago. And we have an opposition with deep ties to conservative trade unions and so on. So, we don't want to underestimate the challenge of legislative change, and there'd be an argument that putting this up now, things might actually go backwards. So I think there's a very strong argument that we absolutely need to be agitating and keeping this in the public eye, and hopefully, not going to put any pressure on you, Mary, hopefully, this is shown to be safe and effective within the next year or two, and that those initial data will be a real spur to making things happen in Australia, because we need to be lobbying individual politicians and families going to make connections. We've seen in the mitochondrial field how that's influenced public policy in the past. So it is a very different country, and we'll be able to use a lot of the UK evidence clearly, but it's not a trivial matter yet.
Yeah, that's a very good point. We are very conservative here in Australia.
The government may be more so than the population.
Yeah, maybe.
I just wanted to ask a question more along the lines of, because of the issues with surrogacy and people flocking overseas, where, laws take a long time to actually be brought and placed, and people flocking to various, your country, the UK, and, is this provided for, for women who are desperate to have children, say they're 35, the age of 35, and, they need to sort of go ahead and, do the, have the IVF, and, is it only available to UK residents or people who are related but by grandparents, or even, people in the European Union?
Everybody wants to answer.
Okay, so the first point is, I think people should not wait till they're 35. I think ideally this would work that families in the care of physicians would be advised when the females get to a stage where they're, in their 20s, that an option would be to store their oocytes for this treatment. And whether it happens sooner or later, or where it happens, to give them that option at least. And the longer they store those oocytes, the better. In relation to if it doesn't become available in Australia, whether the treatments could be done in the UK, I see no reason why not. It would be funded by the NHS in the UK for UK people, but as private. But within Australia, it could be that people, young women, would store their oocytes for future use.
There's an increasing number of women storing their eggs in Australia. We've collected data for the first time this year, and certainly with some reliability increasing, that's certainly changing. And I think it's the comment about cross-border reproductive treatment is very true. People are using the internet, and they're going where the treatment is available. So I wouldn't be surprised if the treatment's available in other jurisdictions, that people do travel if legislation is slow for you to change.
Mary, can I ask how soon do you think you will be actually able to use the techniques in the UK? Next year?
No, it's difficult to say. We're in the final stages of research. We submitted our paper for publication. We've got some more experiments to do. We're doing those now. Hopefully we'll be published. That triggers a sort of expert panel. We will reconvene. We'll reassess the evidence. They will ask whether we've addressed all our concerns. If we have, then we could apply for a license. And the licensing authority would then review our ability to deliver a treatment. And so it could take some time, and I really don't know okay, well, the expert panel would ask us to do some more, so it's impossible for me to say. Both. So they will examine the centre, look to see does the centre meet several specific requirements, and then on a case-by-case basis they would assess the patient need, which, you know, a lot of people have problems with, because I think families are in the best position to decide whether they want to pass that disease on. So that's the way it's going to work.
Okay, any further questions, or shall we wrap up? I think we're 5:30 is probably a good time to call it a day. So I think we'd just like to, the tall man at the back is gesticulating, he even has some small bags. Well, I think just like to, while you're handing out prints, thank the speakers once more for a really great series of talks. Thank you. And what we'll do now is we'll go away and we'll make a synopsis of what we've been talking about today, and try to start putting together a bit of a position paper on mitochondrial donation, so that we can start using that to start doing some of the communications we've heard about in the UK, getting it out there and really articulated amongst the different audiences that it needs to be done with. And I'd just like to thank Sean and Rebecca for all the great work in getting this organised. Two meetings in 3 days is never easy, and to Julie, of course, down at Monash, who's done a lot of work for me as well. So thanks again to everybody, and enjoy the rest of the evening. Thank you.